Welcome, everyone. It's my pleasure to introduce our session today. I'm Dr. Jessica Kendrick. I'm a nephrologist and professor of medicine at the University of Colorado, and we have a fantastic session for you today. We'll be discussing about learning the ways that chronic kidney disease can impact the pregnancy experience. We're going to hear from a provider as well as two patients about their journeys, their perspectives, and their advice for patients with chronic kidney disease. So I'm going to introduce our panelists for today's session. First, we're going to have Dr. Angie Lobo. She's a senior fellow in the Division of Nephrology and Hypertension at the University of Minnesota. Her research is focused on kidney disease in women, particularly kidney disease caused by autoimmune disease. Our first patient speaker is Thelma Barber, who is a patient advocate living with chronic kidney disease, hypertension, and type 2 diabetes. She's also a 2-time kidney transplant recipient. And then our final patient speaker today is Crystal King. She's a patient advocate, nonprofit founder, and an experienced marketing and digital ad strategy professional. She's a kidney transplant survivor using her experience to advocate for kidney disease awareness. So welcome, everyone. It's great to see you all here. As we get started, for all of you joining us, I want to encourage you all to please type your questions and comments into the chat box. We'll try to get to all of these at the end of the session during our Q&A segment. And right now, I'm going to go ahead and pass it over to Dr. Lobo, and she's going to begin her presentation.
Hi, good afternoon. It's truly a pleasure to be here. I'm very excited to give this talk. This talk is very close to my heart and to my research. So as Dr. Kendrick was saying, I am a senior fellow at University of Minnesota in nephrology, and my research is exactly in women with kidney disease. So these are my disclosure. I do hold a grant from the National Institutes of Health for support for my research in women with kidney disease. My other disclosure is that I've been pregnant twice, so I know the importance of this topic. However, I'm not a kidney disease patient. I did not put it here, but my next disclosure is that my sister went through preeclampsia twice and developed kidney disease during her pregnancy, so this is extremely close to my heart. Next slide. So what is it exactly that we'll be learning today? So first of all, we need to understand the impact of CKD, which is chronic kidney disease, on pregnancy. And how is it that we're going to manage chronic kidney disease while being pregnant? 2 is how pregnancy can affect the development or progression of chronic kidney disease. What considerations should we take, how to manage CKD during pregnancy, and what changes or modifications to our therapeutics have to be made? And lastly, which strategies can we use and implement to promote a healthy pregnancy with chronic kidney disease? And that way we can avoid further complications. Next slide. So let's start off with a simple case. This is a 29-year-old woman. She has a history of systemic lupus erythematosus, which is commonly known as lupus or SLE. This is complicated by lupus nephritis. Basically, it's that now it's affecting her kidneys, and she's currently treated with mycophenolate, hydroxychloroquine, and prednisone. She comes into my office or to another nephrologist's office, and she's asking, what is my chance? What is my possibility of becoming pregnant? Next slide. So to start, I want you to know this is that kidney disease is not a barrier to reproduction. However, let's highlight that this occurs in most patients. However, it's an important part that we need to evaluate the risk and benefit of becoming pregnant while having chronic kidney disease. The care that's going to be provided to this specific patient population, it's based on very limited clinical evidence. So I really like this quote. It's from Jim and Hugh, and it was published in a journal that says, "The miracle continues against all odds. Everything's against you, but this miracle can happen." Next slide. So let's understand first a couple of changes that do occur in a quote-unquote normal kidney when a woman becomes pregnant. The first thing is that the kidney is actually going to grow quite a significant amount during pregnancy. It will increase 1 to 1.5 centimeters, and the whole volume will increase by 30%. Then because of this and the extra volume that a pregnant woman has, is that there's going to be some enlargement into the duct system. So all those tubes and spaces where the urine is produced in the kidney, they're going to also enlarge because there's going to be some degree of backflow of urine into the kidney. I always say to my patients, kidneys are beautiful organs, but they are greedy and they like their blood flow. So in this case, also, they're going to require an increase in the blood flow of approximately 80% above the normal. Then there's going to be some changes in those common markers that we hear from providers or clinicians. And we're talking about creatinine. So we know that creatinine is something that you discuss constantly with your doctors, but creatinine will actually fall during pregnancy. The first trimester, we expect that this creatinine number is going to come down, and it's suspected that it's going to be by dilution. So then the filtration rate of those kidneys, they're enlarged now, it's going to increase actually around 40 to 50%. Then there's other changes that will happen. Sodium, uric acid might change, and that number, the BUN or BUN, will also fall between 8 to 10%. Next. So planning. So this should start before pregnancy. So I want you to make a plan, discuss it with your care team, discuss it with your family, discuss it with your network if you feel comfortable with. However, it's very important to bring it up prior to becoming pregnant. That way you have the opportunity to optimize medicines, optimize your blood pressure, optimize those protein levels in urine, and have and build a multidisciplinary team that includes your general practitioner, your nephrologist, your OB, and everyone that needs to be involved. Then timing and fertility. What stage of CKD do you have? Is it an advanced stage or is it an early stage? Do I need to optimize dialysis to be able to achieve this? Then, do I need to control diabetes? Do I need to control my blood pressure to prevent further complications along pregnancy? Do I need to stop any of the medications beforehand versus stopping them right at the moment of pregnancy? And which ones may I continue? We should optimize her nutrition. So maybe considering having a consult with a dietitian, with a nutritionist, discuss her weight, discuss how much protein can we have during pregnancy, how much potassium, what type of vitamins, should I take more or less of folate and vitamin D and calcium? And then other things such as that will include planning is pregnancy not the best at this time? And what are my options? Should I consider fertility preservation? And what type of contraception should I use? Next slide. So what is the risk of becoming pregnant while having chronic kidney disease? Well, there's certain risks that pertain to the mother and some pertain to the child. So the biggest risk and what women fear the most during chronic kidney disease, one is the progression of the kidney disease. And two is what's going to happen with baby. So there's actually higher rate of preterm deliveries, so delivering before your due date. Their C-section rates may increase, and then you should plan for a care for yourself and baby if any of these do develop. Some babies might be smaller than expected, and then there's including the risk of having stillbirth or death. So this is something to evaluate, but it's very independent from woman to woman and from the stage of chronic kidney disease. Then there's risk of developing preeclampsia, which is hypertension during pregnancy. And then there's also probabilities of worsening of systemic disease. So if you have diabetes or you have lupus, what is the risk of these diseases becoming worse during pregnancy? Next slide. So a nice checkbox that I use is promoting a healthy pregnancy while being a woman with chronic kidney disease. So you should have a care team. So note which one should you involve in your care team early versus not. What changes should you have? Should I monitor closely all my weight, blood pressure, sugars? Have a journal for this. Avoid excess weight gain. What changes in medicine should I implement? And then plan for more frequent follow-up visits with your providers. Next slide. Okay, so you're pregnant. Now what? So the first thing that you should do, other than calling family or friends, is give a call to your primary care physician. Let them know that you're pregnant. Also, send a note or give a call to your nephrologist, to your kidney doctor, and establish care with an OBGYN. You need a multidisciplinary team to make it successful and avoid further complications. Set up your appointments throughout pregnancy. Make a plan. However, we women are planners. However, this plan might change constantly during pregnancy. So also be prepared for those changes to happen. Keep track of your health. Again, as I was mentioning, keep a journal. Weight changes, blood pressure, what medicines, what appointments, the food that you're taking, and mental health. Remember, a healthy body also needs a healthy mind. And consider journaling. I honestly believe that sharing your experience with others, as we are doing here, is extremely encouraging and building that team, that village to be able to share your story. Story is very unique to you and it won't apply to other patients. However, you can share your story and build a community from it. So next slide. So what changes occur in kidney function during pregnancy? Well, in the first trimester, as we had discussed, is that creatinine we expect it to decrease a little bit. That filtration rate might increase. So these are things that your physician will be monitoring. During the second trimester, we expect some sugar in your urine to be increased. Then the glucose tolerance test will be performed around 28 weeks. That sugar load that your OBGYN makes you drink to see if you have gestational diabetes. So this should happen around week 28. Your blood pressure might improve during the second trimester. And then during the third trimester, this is where we get concerned about the kidney function. Pregnancy is a significant stress to your body, and your kidney function might decline during the third trimester when everything is at its most. And then in birth, this part is very close to my heart because I feel that women after they deliver, we're so busy with everything. We're busy with childcare, with everything of all the dynamics with work and family that we often forget that we need to take care of each other. So making those follow-up appointments and monitoring that kidney function post-pregnancy is cornerstone. Next slide. So again, changes to your treatment plan may happen, and they are individual to each patient and disease. So changes for chronic hypertension, which is high blood pressure, lupus nephritis, autosomal dominant polycystic kidney disease, or non-ADPKD, diabetic kidney disease, kidney transplant, patients with IgA nephropathy, and other things, including end-stage renal disease, which is patients who are on dialysis. So everything's very unique to each patient. Next slide. So this is a loaded slide. However, I just want you to focus on a couple of things. We're building muscle memory here. So I'm going to be repeating a couple of items throughout the talk. Your creatinine. We had discussed that there's supposed to be a fall in creatinine during your first trimester. So what is the percentage that we expect it to fall? At least 10%. So if this doesn't occur, this is something that will make your physician, your provider, concerned that there might be a possibility of progression of kidney disease during pregnancy. The eGFR, which is that percentage of kidney function, of filtering kidney function, we usually don't use this during pregnancy. There's a lot of changes in the volume status that may alter the GFR. So what we do is we take that GFR that you had prior to pregnancy and use it as a baseline. And then the protein in urine, it might be increased because of all that pressure there is against the kidney and volume that it's receiving, that there might be some changes within the kidneys that produce you to spill it a little bit more of protein into the urine. So there's really no accepted thresholds that we could use during pregnancy. Next slide. So chronic blood pressure, high blood pressure, chronic hypertension. So this is an area of debate of what is that target blood pressure that we should have in patients who become pregnant. In the past, there was a concern that too low of a blood pressure might affect the blood flow towards the placenta and affect baby. So we would treat our patients to higher thresholds of blood pressure. However, there was a big study that was published last year that showed that keeping blood pressures below 140/90 is acceptable and there is no risk to the baby. So that should be our target, having blood pressures less than 140/90 during pregnancy. We should avoid too low of a blood pressure or too high of a blood pressure. So we need that nice middle ground, and this is why it's very important to have a cuff at home, be monitoring your blood pressure, and if you start noticing that your blood pressure is maybe a little too low or a little too high, getting a hold of your nephrologist or your primary care physician is the best idea. Next slide. So again, loaded slide, but we'll be focused on a couple of things here. So blood pressure medicines during pregnancy. So you might have a regimen that you were using before pregnancy, or if you do become hypertensive, high blood pressure during pregnancy, the first line therapy that we use is a medication called labetalol. Then we can also use nifedipine. And in other countries outside of the US, methyl-dopa is one of the most common medications used for blood pressure during pregnancy. Those that are contraindicated and should be stopped before or immediately once you become pregnant are ACE inhibitors like lisinopril. ARBs like losartan or valsartan, these should be stopped at the moment of pregnancy and even better before pregnancy. And then diuretics will leave to discretion of your care team. There's some patients that do benefit from diuretics during pregnancy, but they do need close monitoring. Next slide. So aspirin, so all women who have kidney disease will benefit from being on a low dose aspirin, which is that baby aspirin that you can buy over the counter. So this is to prevent development of preeclampsia, which is hypertension and other organs that get affected during pregnancy because of this. So the American College of Obstetrics and Gynecology actually recommends all women that have kidney disease to start that baby aspirin around 12 weeks and continue the baby aspirin until delivery. There's always a concern of bleeding when you take a aspirin. However, studies have shown that the risk benefit, there's more benefit in taking the baby aspirin rather than the risk of bleeding. There's very slight increase of risk of bleeding. Next slide. So for kidney transplant patients, you know that your care coordinator is on top of things, that your transplant team is on top of things. So they need to be very well involved and know exactly when are you planning to become pregnant, if you are pregnant, how many appointments they need to modify, what blood checks they need to change throughout the pregnancy, and then your immunosuppression. So when we discuss glucocorticoids like prednisone, this may be used in pregnancy. However, knowing that while you're on prednisone, it does carry some risk. Maybe there's a risk of intrauterine growth restriction, which basically means smaller babies. There's a risk also at high doses of steroids that the adrenal glands, which are these glands inside the body on top of the kidneys, might be suppressed because of these high doses in the baby. So discussing with your care team is cornerstone to benefit pregnancy during this time. Then another medication is AZA, which is azathioprine, commonly known as AZA. Safe during pregnancy, however, it can lead to lower white blood cell counts in babies. So it's also very important to know what dose exactly should you be on during pregnancy, because those high doses might have a risk. Then other medications like cyclosporin or tacrolimus, which is commonly known as TAC, it does freely cross the placenta. However, they're safe during pregnancy and they do require closer monitoring because that target that we want to keep patients in will change throughout pregnancy. Next slide. The ones that we avoid is MMF, which is mycophenolic mofetil or mycophenolic acid. So these are contraindicated and they do need a washout period, which means that they need to be stopped several months before becoming pregnant in order for the medication to wash out of the body and then get pregnant. So this needs a discussion and planning because they're highly teratogenic, which basically means affecting the baby. Sirolimus, everolimus are also contraindicated, and newer medications such as belatacept or rituximab or eculizumab, they're right now not used in pregnancy. There are some studies that are undergoing to evaluate the safety of these. However, they're not recommended as of now. Next slide. So lupus nephritis. So with lupus, timing is everything. So why is it that timing is everything with lupus? It needs planning. It needs to be in remission at least 6 months before becoming pregnant. And then we need a pregnancy-friendly treatment regimen. So very important, what has been studied in lupus nephritis is exactly what was your pre-pregnancy history. Was your lupus quiet? Did you ever achieve a safe and successful pregnancy before this one? And if these things line up, then they're able to predict how your pregnancy will be. So it's very important to know exactly what happened before pregnancy in order to prevent further complications during this current pregnancy. So the risk of preeclampsia is actually around 30 to 35%, anywhere from 10 to 35 in lupus patients. So the usual treatment of lupus is contraindicated in pregnancy. However, we know that we can have patients on azathioprine, hydroxychloroquine, and okay to use some steroids in them as well. So it's very important communication and knowing exactly what was your prior to pregnancy baseline. Next slide. Diabetic nephropathy, it's again, another checklist that must be done before pregnancy. And it's important to know which medicines you're going to stop. What is the control of your glucose before becoming pregnant, and knowing what is going to be your target of A1C before. Controlling your blood pressure, which may be a little different for diabetic patients. Getting those heart checks, eye checks, lipids, what is your risk of clots, knowing all of that is very important to achieve success. Then, should you be on a higher dose of folic acid? All patients should be on baby aspirin. Then knowing your baseline kidney function before becoming pregnant and knowing what protein level you had before in order to be able to monitor adequately. We need a lot of team, so nephrologists, endocrinologists, OBGYN, primary care, and then postpartum control to make sure those blood sugar levels and your kidney function return back to a baseline. Next slide. So ADPKD, which is autosomal dominant polycystic kidney disease. So the fetal complications, so complications related to baby are similar to those patients who have non-autosomal dominant PKD. So there is maternal complications that are associated to this. However, in these two populations, the autosomal dominant and the non-autosomal dominant, they saw that maternal complications were a little bit higher in autosomal dominant polycystic kidney disease. It's very important to discuss genetic counseling for your offspring, for your babies. What is the risk of me giving this disease to my baby? And then the complications that we see in ADPKD and non-ADPKD are similar to the ones we see in other patients with kidney disease. So high blood pressure, development of preeclampsia, swelling, increase in urinary tract infections, and worsening of proteinuria in the urine. Next slide. What happens if you need a kidney biopsy? Well, there is a possibility that some patients will require a kidney biopsy during pregnancy. In the past, there were reports that it was risky, that you had a chance of bleed that was higher than the non-pregnant population. However, subsequent reviews, they saw that the way the kidney biopsy was done in the past is very different than the way that we do it now. So most of the time now we can do safely kidney biopsies, even in the second or third trimester. So knowledge is power, and I want you to know that this is a true possibility that may happen during pregnancy, that you could require a kidney biopsy. However, we know that it can be done safely. Next slide. So let's say you're just not ready yet. So discuss with your primary care, discuss with your OBGYN or your gynecologist about contraception. So what is the best contraception I can use right now because I am holding off pregnancy? And then what other options do I have? And this is very much related to the stage of CKD and to the age of the woman. So fertility preservation is an option, which is basically egg freezing, embryo cryopreservation for a later transfer through IVF, or gonadal shielding. Gonadal shielding is a treatment that's used specifically in those women who take medications that will affect the ovarian function. So we can use other medications to shield those ovaries to protect them against harm from these medications. So advantages of this is that you have the chance to optimize your health for the future. So it's not a no, it's a chance to optimize your health. To avoid further complications, including progression of kidney disease or in dialysis. Avoid transplant rejection. So women who receive transplant, most of them will have restoration of their fertility. However, timing of when is the best time to get pregnant post-transplant is very important to discuss with your transplant nephrologist. And change those medications to avoid teratogenicity, which is harming the baby. Next slide. So a couple of take-home points. So pre-pregnancy is that pregnancy is possible in most women with kidney disease. Control of blood pressure and proteinuria, protein in the urine, is key to achieve a good pregnancy and avoid progression of chronic kidney disease. We need medicine management, so changes in those therapeutic regimens, and planning. And then you do need a multidisciplinary team because it actually does take a village. It takes a village for a woman without kidney disease, but it also takes a village for one with kidney disease. And that includes family, includes your primary care, includes OBGYN, includes your partner, includes your nephrologist. And then pregnancy and post-pregnancy, know that your plan, your initial plan that you had might change throughout the way. So knowing that those curveballs might come throughout pregnancy is actually very good to plan for those, which is very difficult, but just knowing that those may happen. Discuss those possible scenarios with your nephrologist. What happens if I end up in dialysis? What happens if my kidney disease progresses? What happens if my numbers are not lowering as expected? So discuss those points with your kidney doctor, knowing that those numbers such as creatinine and GFR might change throughout pregnancy. And then knowing that there's a true possibility that there might be some degree of progression of kidney disease. So it's very important to follow up closely with your kidney doctor pre-pregnancy, during pregnancy, and after pregnancy. Next slide. So this is my last slide. So counseling for your patient, our patient, our population, well, we tell them that we do need a multidisciplinary team approach. So everyone has to be involved. We have to discuss fertility considerations. So what is the age of the woman who's in front of me and wants to become pregnant? What stage of CKD, chronic kidney disease, does she have? Is she a candidate for transplant? And when is that transplant going to occur? And if it does occur, when is the best time for her to become pregnant? What are her menstrual cycles? We know that menstrual cycles change throughout chronic kidney disease. So what are they now? And they may change as frequency of dialysis changes as well. And then discuss the possibility of delaying pregnancy and fertility preservation. So knowing that there's that risk of progression of chronic kidney disease, that there's a risk of ending up in dialysis and needing dialysis, whether that's temporary or permanent. There's a risk of miscarriage, preterm delivery, smaller babies, and the risk of preeclampsia is very high in the kidney disease population. So if this is not something that's achievable, also consider discussing other options with family. Surrogacy or adoption is other options to be discussed. So again, just to reemphasize, pregnancy is not impossible having kidney disease. However, it requires planning. It's achievable in most patients. There is risk associated. So at the end, it's a risk benefit balance that has to be made from your standpoint, your family's standpoint, and that village that I was discussing about your kidney disease doctor, your primary care doctor, your OBGYN. So it does require a lot of planning. It does require a lot of discussions. It does require a lot of appointments, but it is achievable. And it might be an option for most women who have kidney disease. Thank you so much. Back to Dr. Kendrick.
Thank you very much, Dr. Lobo. That was amazing. I learned so much, and I'm sure everyone appreciates that. We're now going to hear from one of our first patients that's going to share her story with us. And so I'm going to turn it over to Crystal, who's going to come on and share her story with us. Looks like we're getting her up here. Oh, well, I don't know if we lost Crystal. Her screen just froze, she said. Okay, well, why don't we going to just, you know what? We're going to go to Thelma instead, our other patient who's going to share her story with us. So here she is. Thelma.
Hi, how are you all? Thanks so much for having me. I am excited to be a part of this talk because it is near and dear to me. And I so thoroughly enjoyed Dr. Lobo's presentation because it really spoke volumes to what I endured during my journey. My husband and I have been best friends, and I've known him for over 40 years, and we're married 29 years now. And so we always knew we wanted to have kids. But in 1993, I was diagnosed with IgA nephropathy, nephrotic syndrome. And prior to that diagnosis, and even during that diagnosis, I was able to get pregnant, but I had lost two. So I wasn't able to carry to full term. And so, it was devastating experiencing that on top of kidney disease and wondering if we would ever have this family that we wanted. And my husband wanted 10 kids, but I was like, I'm not trying to have 10 because I am a twin. And so he was like, oh, we probably all have twins and we can have 10 kids. But I'm like, no, we'll just get what we can and whatever God bless us with. So with that said, we had tried prior, and it was difficult because along with me having the kidney disease, I also was overweight. And so come to find out, being overweight also plays a role in fertility issues. And so I did everything that I could after being diagnosed with kidney disease. I lost weight and I was like, yes, now I'm down to weight. I've got this new kidney. We can have this baby. I was told to wait 2 years after I could conceive after the transplant, and we tried. And we were blessed for me to get pregnant, and we didn't get 10, but we was blessed to get the miracle 2. But what I loved about Dr. Lobo's presentation, plan, plan, plan. We knew that we wanted to do this. but we knew we could not walk into that situation blindly. And when she mentions a multidisciplinary care team, we had to have a high risk OBGYN. We had my primary care physician. We had my nephrologist. We had family. We had pastors. We had everybody because we knew once we embarked on this journey, it was no turning back. And we knew that it was going to be high risk. And so once we found out I was pregnant, guess what? The miracle happens. I was pregnant with twins, two boys. How beautiful is that? But during this process, when I'm going through this, and I realized, yes, I'm pregnant, we're excited, we're going to do this. Um, the doctors were highly concerned about me moving forward with this pregnancy because unfortunately, the proteinuria from my IgA nephropathy started to present itself again. My kidney disease my kidney started actually failing. So it's one of those things, well, you can go through with this pregnancy because either way, whether you go through or not, this kidney is not going to last. They feared that I was going to have preeclampsia, and they said, you know what? We think that you should decrease your pregnancy by one. I said, I don't believe so because God doesn't make mistakes. I was blessed to get back the two I lost, and we're going to go through this pregnancy. But that meant a lot of dedication. It meant a lot of hard work. It meant that I have to watch what I ate. During my pregnancy, I blew up to about 80 pounds in fluid. I never forget. I couldn't even put on shoes. I had to wear slippers because my feet had swollen so bad because of all the water I was retaining. Medications, even prior to getting pregnant, I had to clean my system out for 6 to 8 weeks. They had to change over a lot of my medication because they knew what was safe in pregnancy, what was not safe in pregnancy. And apparently, I guess with me staying on prednisone, it did cause what Dr. Lobo said, the condition of the interuterine growth retardation. Because at that time, my children were not growing well in my system. And we had to do an emergency C-section where my twins were born at 29 weeks. One was 2.4 pounds, one was 2.9 pounds. And today, my children are thriving, and I'm grateful. But going through this process, I had to stay on bed rest from the moment I felt I was pregnant until I gave birth with the kids. So when you do decide to go down this path, understand that there are risks. But does the risk outweigh the benefit? And in my situation, it did because I prayed and I wanted to have these kids. I was fortunate to get pregnant, and there was not going to be anything that was going to stop this dream. And so, what I tell you today, follow the advice of your physicians, plan, 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 because that is the key to your success. And I hope that my story can encourage you all that it is possible. And as the quote said earlier, I believe it was a miracle. Let me see, I have written it down. The miracle is against you in all odds, but at the end, God has the last word and say over what will and will not happen. Thank you so much for having me today. I appreciate you all.
Thank you so much for sharing your story. That's wonderful. I appreciate you sharing all your experiences with us. So now we're going to turn it over to Crystal. I think she's back, and she's going to share her story with us. There she is. Hi, Crystal. Please go ahead.
Hi. So I am Crystal King. I was diagnosed with chronic kidney disease at age 14 after waking up one day completely swollen and unrecognizable. I was diagnosed with glomerulonephritis. It didn't really have a major negative impact on my life until I got 36 and we decided to start a family. I was kind of like the example of how things should go right because I was diagnosed so young. I knew, what to expect. Me and my doctor, we planned for it. She told me that I would have to follow a fetal specialist. And so we thought everything would be okay. From the very beginning, we're following the doctor, the fetal specialist. We did have to switch my to a different medication. And things were, I guess, going as good as they could be. For it was a normal pregnancy in the beginning. Then around the 6 month mark, my high blood pressure was no longer being controlled by the medicines that I was taking. We had switched medicines a couple of times at this point, and we were running out of options. And so I did have to begin an emergency bed rest. I wasn't expecting that, but I did have to go out on bed rest. And I developed preeclampsia. And I feel like I had all the risk factors that Dr. Angie talked about. And after being on bed rest for about a month, my blood pressure still wasn't being managed or controlled by the bed rest. And so my blood pressure was very, very high. I can't remember what the bottom number was, but the top number was in the 180s, 190s. I was at risk of having a stroke. And so I had to go into the emergency room. And that's when, I found out that they were going to keep me and that I would have to have an emergency C-section. So I delivered my son Avery. He was born at 4 pounds. I had taken a injection to speed up the development of his lungs, and so that he would be okay to be delivered that earlier a week prior, because we knew that something like this could happen. And so he spent about a month in the NICU, and I spent about a month in a nearby hospital room. Literally, the room beside the NICU was my room, because I was now in kidney failure. I was told that I would need to find a living donor, and get listed on the kidney transplant wait list as soon as possible. So for me, the pregnancy did send me into kidney failure. Like I said, I had kidney disease before, but the pregnancy did send me into kidney failure. But there was some recovery from the pregnancy. And so I was told that, and I did need the kidney immediately, but that I needed to start looking. And that was in 2017. And in 2020 is when I found out that I would need to start dialysis or get a kidney transplant, because the disease had progressed to a level where that was imminent. Now, I feel like the EGFR calculation, which was based on race at the time, has something to do with like me not qualifying for dialysis or transplant back in 2017. And so I'm glad to see that calculation has been updated. The race factor has been removed so that we can detect kidney failure in people like me a lot sooner. If you want to get pregnant while you have kidney disease, my biggest, thing is definitely talk to your doctor about it. Like she said, pregnancy and kidney disease is not for everyone, depends on a lot of things, what stage of kidney disease you are, as well as your health and everything. And so I would definitely talk to your doctor, to find out, if it's something that's right for you, and consider other options, because the pregnancy sent me into kidney failure. I did have my tubes tied, but I'm happy to adopt. I would love to adopt, another child so that my son can have a playmate. But yeah, I would, definitely talk to your doctor, let them know what your plans are, and figure out what's right for you.
Wonderful. Thank you so much for sharing, Crystal. That was an amazing journey you've been on through all of that with pregnancy. Well, thank you for sharing. I think now we can open it up for some questions. And so I think we'll bring back all of our panelists here, and they're all here. So I'm going to go ahead and start with just one of the first questions that we're having come through in the chat. Maybe we'll start with Dr. Lobo on this. Can a woman who is on dialysis have a baby?
Yeah, that is a great question. And, it's a little bit more complicated. It comes down to checking the levels of BUN, the frequency of dialysis, because that hormonal axis that occurs between the brain and the ovary does get affected during dialysis, does get affected during chronic kidney disease, especially at later stages. There is a possibility, and it depends also on the type of dialysis, those women who are on dialysis, and specifically home hemodialysis, get more frequent dialysis. So their BUN levels are lower, and also that access can be restored with more frequent dialysis. So that is achievable in more frequent cases. In those who are in center dialysis 3 times a week, it's a little bit more difficult because of that access that we're talking about, and infertility is real in this population. So it may happen, and that's where the miracle occurs. It may happen. However, it's very complex, but it can be achieved.
Oh, great. Thank you. Thelma, Crystal, any thoughts on that? That's okay if you don't have any, because I think, you've kind of been through the whole spectrum there. Well, and I think, for both of you, especially Thelma, having a child, with a transplant, other things that are like that, obviously it can happen. Do you feel like you might have done anything differently, or should the providers have done anything differently with your journey in terms of like preparing you for all of this?
No, I think that my husband and I, we were well prepared. I must say that, I always tell people my nephrologist is like my BFF, and he really spoke life into the things that I wanted to do. He led me down the path of everything that I needed to do to make sure it was right. And so, like I said, what Dr. Lobo said, you have to plan. I had to clean my system out. We had to make sure that the medications that I was on, I was not on. When we switched my blood pressure medication, I was on verapamil. They switched me to nifedipine. Nifedipine worked, but guess what? Blood pressures crept. I was doing good, but as I continued weeks into the pregnancy, my blood pressure did get out of control. So then that's where I think I retained all the fluid. So when she said, talk to your doctor about diuretics couldn't help. I was so blown up. I never forget my cute little Snoopy slippers. That's all I could put a foot in. And it got to the point where I couldn't walk. And my husband, he's so crazy. He got a wheelchair to push me in because the fluid was a lot. And I know that it was because after I had given birth to my kids, I was like the thinnest I've ever been in my life because it was a lot of fluid. So, my doctors did a phenomenal job, and you do have to partner with them because that's the key to success.
Great.
I
So,
agree with that. I think you definitely need to talk to your doctor. This isn't something you want to do without talking to them, because a lot of medications that we take could harm the baby. And, like they said, there's some things that may have to be flushed out of your system months prior to. And so I would definitely talk to your doctor if you're planning to get pregnant.
thank you. I mean, I think sometimes, they can talk about it. That's great. What do you recommend? And maybe this is kind of to Dr. Lobo. Obviously, pregnancies are going to happen without planning. In someone who has kidney disease, can a pregnancy still be successful without all of this planning?
Yeah, absolutely. It can still be successful. However, I'm going to reemphasize the planning part. We don't like the surprises, but if we do encounter them, it can be successful, knowing that there might be some risk associated. So knowing that the kidney disease might progress, that medications have to be switched immediately, and there might be some risk of harm to the baby having been on those medications that are contraindicated during pregnancy. So it can be success. However, the question is, what is the definition of successful? And knowing that there was going to be a lot of risk associated when it's an unplanned pregnancy.
That makes sense. Thank you. So do you, another question that's come through is, do you have to see a high risk OBGYN, or is a normal OBGYN okay?
Yeah, I can take that. So ideally, maternal fetal medicine, which is MFM, it's high risk pregnancy OBGYNs, should be involved. So kidney disease is a complex interplay of a lot of stuff, right? Medications, labs, frequent visits. So ideally, and also because of the risk to the baby and having that risk of early delivery, ideally a maternal fetal medicine specialist, high risk OBGYN should be involved.
Mm-hmm.
Okay, great. Thelma and Crystal, did you have that? Did you see a high risk OB during your?
Yes. Yes.
So, and you probably had your regular OB there as well, I'm assuming, and then saw maternal fetal medicine. So they can still see their regular OB, but just have maternal fetal medicine involved.
Correct.
Okay. That's great. Okay, wonderful. Another couple of questions that have come through is, do you have to stop or change your immunosuppressants during pregnancy? Dr. Lobo, maybe that's back to you again.
Yeah, I can take this first. So yes, most of these medications, there's several medications that are used for immunosuppression during a kidney transplant. But specifically, the one that we are very concerned of is the quote unquote MMF, which is mycophenolate or mycophenolic acid. This needs a washout period. So you need to be off these medications for at least 3 months before becoming pregnant. So it does require a lot of planning. However, it's extremely important because this medication is highly associated to birth defects. So patients need to be off, and the dosing will change during pregnancy. So the tacrolimus actually there's going to be changes in the blood levels. So there's going to need more frequent monitoring, and you might be at higher levels of tacrolimus during pregnancy. So once you deliver, you need to see very closely your labs and your transplant coordinator and your transplant nephrologist in order to go back down on the dose of tacrolimus.
Mhm.
Okay, great. And this is a question towards Crystal and Thelma that someone's asking. So what was the post-pregnancy recovery like with kidney disease? So Crystal, you want to go first?
Oh my gosh. It was bad for me. It was so bad because I was in kidney failure. And it's hard to say, like, is this pain from pregnancy? Is the pain I'm experiencing from the kidney failure? Or the anemia or the high blood, all the things that you develop. So the recovery for me was like, it was not good. I hate to say that. I was in the hospital, for a while after pregnancy. And then I remember, so I gave birth to my son in March 28th. He has a birthday coming up. And I didn't really start feeling good until, I don't know, July, August. So it wasn't that great for me. And we had a plan in place. I had a good family support system. I'm from Georgia. My family, we've been here for over 100 years. I have like thousands of cousins and aunts and uncles, and everyone's down the street helping. But my body was just not, responding well to the kidney failure.
Okay. What about you, Thelma?
Well, for me, I echo that because I was still going through the releasing of all that fluid. Plus, I had the C-section, and my twin stayed in the NICU. So one was in for 50 days, and one was in for 70 days. And so it was difficult trying to manage, do I go see my kids? And that was guilt because my OBGYN and everyone medically from the doctor said, no, you need to stay home and take care of yourself. And I did the best that I could in taking care of myself. And as I said before, unfortunately, the kidney was kind of going on the fritz and out anyway. And so I lacked a lot of self-care because you're running with the twins when they finally did come home, one up, one down. You're trying to get them on a schedule. My husband worked overnight, and so I stayed home with the kids. And support system is key. You really need a village. And although at the time we were in New York City, I had relatives, but they were upstate New York. And then I had a relative that could help, but they were too old, And then you try to find a babysitter or people that you can trust because your kids are coming home. Well, one came home on oxygen because he had like the suck, swallow, and breathe kind of issue. And so he needed oxygen when he was fed. And it was just a lot. It was overwhelming. But, you do need a support system. You need a village. And you can do as much planning as you want to, but things do fall apart.
Yes, that's true. Sometimes all the planning in the world and things, and just like, I think that was very important what Dr. Lobo said, just be ready for that. Like things aren't going to, your journeys are exactly that. You had it planned one way and curveballs came left and right for both of you. So someone did ask in the chat, if you do you have advice for how to build that support system? So, Crystal, you had yours there, had all this family. Thelma, not so much. Is there some way else to build it, like with friends or support groups, or any advice you might be able to give on that?
Well, I think because my kids were premature, the advantage that I say I had was that there were social workers at the hospital that gave me advice on what to expect. They had already told me that, my kids were probably going to have therapy with some things. So I guess my advice would say is contact the neonatal clinic, at your at the hospital to see what resources they could advise you. Because when I came home, they did give me information because my kids, after a couple of months, did have to have some therapy. So they had something called respite services where a nurse came in for a couple of hours to help because one did come home, with oxygen. But I would say to rely on the OBGYN's office and talk to social workers there to see if there are community um, places that you can go to for assistance, or even maybe contact your local social services department. And then rely on your church. That was always a huge thing for me.
Oh, that's great.
I
Crystal,
agree with
any advice?
Yeah, no, I agree with that. I didn't find out that there was a NICU support group until months later. When I was feeling better, I wanted to go and thank them and like donate clothes and blankets and whatever they needed for like the other babies. And that's when I
Mhm.
found out that they had a support group. And so I think support groups are very helpful. You meet other people who are in a similar situation as you. And, that can be very encouraging and inspiring, just to have someone to talk about this with.
Mhm.
Yeah. Yeah, that's a great. I never even thought about that. Just finding out what's available, and even probably pregnancy. There's lots of different
Mhm.
support groups for women with kidney disease, and perhaps
Mhm.
we need some better ones for specifically like this, just so women can ask these
Mhm.
questions. Dr. Lobo, I did want to ask you. So there's, you obviously are a researcher in this area, but there's a lot of data out there that women with kidney disease are very hesitant to bring up their pregnancy planning with their doctors, and specifically with their nephrology doctors. And so I don't know if you have any advice to, the women and the patients listening, and then we'll go to Thelma and Crystal. Like, should you bring it up? Should the doctors bring it up? What do you suggest?
Yeah, absolutely. There was a study that actually showed that only 10 to 20% of kidney doctors discuss women's health issues. So that's the big issue right there, right? We should be the ones bringing it up immediately. What's your family planning? What's your contraception? Are you avoiding pregnancy immediately after transplant? So to begin, the fault is on us. We should be the ones bringing it up. However, if your doctor doesn't bring it up, then you bring it up. Feel comfortable that you're a woman and they're taking care of women. So they should be comfortable managing this. And if they're not, which is okay, not everybody, I'm women's health trained before nephrology. So not everybody has this. It's okay. Who can I see? Who can I see that has the experience in this? Which colleague here in the clinic might have more experience in pregnancy and kidney disease? So being comfortable with that, discussing your planning, your family planning, your contraception, even your menstrual cycles is
Mhm.
very important for a kidney doctor to know exactly what's going on. So
Mhm.
please do bring it up, be comfortable with it. And if not, then somebody else can refer you to someone who is comfortable managing these situations.
Mhm.
That's great. Thelma, Crystal, any thoughts on being on the other side of it, how to bring it up?
I brought it up because it was a goal of mine, but I think if people are afraid to bring it up, that's because you have to start analyzing what is your relationship like with your provider. And I
Yep.
keep trying to tell people your doctor is your lifeline. He's there to take care of you. You are there to inform him of what's happening with your body. And that's why you have to advocate. And I'm huge on advocating. That's why I'm a patient advocate, because the conversations that you don't have are the ones you have to have if you expect to get anything accomplished. But you have to look at your provider as a friend, not a foe. And he's family. He or she is family. They're going to know more, probably more intimate details about you than maybe your own spouse and family might know, you know?
Good
Yeah.
point. Good point. Crystal, what about you? Anything to add to that?
I agree with that. So, because I was diagnosed so young as a pediatric, my mom was really in charge of my kidney care until I graduated college and, got my first full-time job with benefits. And then it was on me to find a nephrologist who would listen to me and who would answer all my questions, someone that I trust. I wanted to find a woman, nephrologist. And so I found one. And I always tell everyone, my relationship with my nephrologist was amazing. Like, I feel like we could have hung out and went to dinner. Like, we were very, very cool. And if you don't have that with your doctor, there's other doctors. Like, you have to find someone who you can trust and who's going to answer all of your questions. And so she knew, like, from my 20s that I wanted children. And so as soon as I went in, I was like, Dr. Sharma, I am getting married. I'm so excited. Like, she was kind of like, I don't know, she was like my diary. Like, she just knew a lot of things about me. And so I told her, and she was like, okay, wait a minute. Are you thinking about getting pregnant? Because we need to talk about that. And I was like, maybe, and she was like, okay, he needs to come with you to your next appointment. And so my husband came with me, like, together. We talked to my nephrologist, and determined, like, how are we going to do this? How are we going to navigate this? What is our plan of action going to be? And so, yes, you definitely want to talk to them about it. She brought it up in my case, but that's also because I was talking to her about my entire life. I was talking to her about dating before I got married. I need help. Like, where am I going to find a man? Like, she knew everything about me.
Well, that's
So she
great.
brought it up.
No, that's wonderful. And that's what we want to hear. So I think this has been very encouraging, that yes, there's a lot of issues and things that can come up with pregnancy while with kidney disease, but we have some success stories. You have your, children at home and had these great relationships. So I think before we close the session, Dr. Lobo, I want to come back to you. Like, can you share maybe one thing to know and one thing to do based on today's session with us?
Yeah, this is going back to my first slide. Kidney disease and pregnancy is achievable.
Mhm.
One thing to do is plan. Plan, plan, plan.
Thank you. Yes, I think we've heard that a lot from the planning side of it, and I think that's great. I think no, you guys gave such great advice, and we really appreciate all of our panelists being here and sharing your stories. Dr. Lobo giving us that fantastic talk, and then thank you to the audience who's been here listening to all of this and putting in all their
Yeah.
questions in the chat. We really appreciate it. So thank you all for joining us. Up next will be the last session of the day, which is going to be on lupus and kidney disease. So please join this session if you want to learn more about lupus nephritis, how it affects your kidneys, and options to help you manage this condition. So, and I think once we conclude this session, you're going to see a brief survey that's going to pop up. Oh, here it is right here. So please take a few minutes to fill this out and tell us how we did. Your feedback is actually really useful, so we know is there other things you want to hear in the future, if anything else would have been more helpful. So thank you again and enjoy the rest of the session. And thank you again to our panelists.
Bye-bye.
Bye.